Okay, so good day, everyone. Welcome to yet another IFMSA webinar. My name is Modupe. I'm the HIV/AIDS and other STIs program coordinator. And today we have a webinar titled HPV, Where Do We Stand? With me, I have Dr. Joel Palefsky, who is in California, San Francisco School of Medicine. And he will be talking to us today about HPV. He's an international expert, and he will be giving us a lot of insightful information about HPV. So, hi, Joel.
Hi, Modupe. Can you hear me?
We're very excited to talk to him. Yes, we can hear you.
Excellent.
Okay, so we'll be asking you questions, and then you will be answering. So for everyone watching, we would love for you to have, if you have any questions, please put them in the chat box in the channel. Then at the end of Joel's questions and answers, I will be reading your questions to him, and he will be answering. So thank you very much, everyone, for tuning in, and we are about to start. Okay, so the first question I will be asking is, okay, you are an internationally recognized expert on HPV, and you are a pioneer in the line of prevention of these infections and the cancers that are related to them. So among STIs that we face today, can you tell us HPV, what media, why HPV, especially workers and relation? You can start.
Unfortunately, I'm going to need you to repeat the question because the line is going in and out. So I lost a little bit of what you said. So I'm sorry, could you repeat that?
Okay. So HPV, what makes it so peculiar, and why do we need HPV awareness in populations today?
So really what you're asking is, why is HPV important? And
yes.
Why should medical students know about it?
Yes.
So firstly, before I start, I want to thank you really enormously for giving me the chance to talk with the IFMSA. I'm very excited to be here. It reminds me of the happy days that I had when I was a medical student. And I don't know if there are any online from Canada, but in case there are, a special shout out. I'm a McGill graduate. And so I do come back to Montreal quite often, and I'm very involved in the global health programs at McGill. But my current appointment is at the University of California, San Francisco. So a special shout out also to anybody who's on perhaps from UCSF. I think what you guys do is really exciting and important, because I know that as a global organization, you can address issues that really span the whole globe. And I think HPV is a perfect example of the kind of thing that everybody really is affected by. And so the problems really are global. One of the reasons why I think this is such a timely topic in this context is because HPV is actually the most common sexually transmitted infection. I remember in med school learning that gonorrhea and chlamydia were the most common, particularly chlamydia, but in fact it's HPV because HPV infects about 80% of the sexually active population at some point in time during their lives. If you do a cross-sectional analysis, of course, not 80% of the population will be positive. It's lower than that. But over the course of a lifetime, about 80% of all people will get at least one genital HPV type at some point in time in their lives. So, in fact, this was one of the reasons why we launched the campaign that we'll talk about a little bit later, where one of the themes was HPV affects everyone. And when I say that, I mean that pretty literally, because there's the 80% who we just talked about. But even if you're not one of the 80%, it affects you too, because almost certainly somebody who you care about or who cares about you has been infected by HPV. So it really does affect the entire population of the world. That's one very important piece of information. The second piece of information that's really critical is that HPV can be a killer. So it's a good news, bad news story, because while HPV affects 80% of people, and that's the bad news, the good news is that only a small fraction of people who get infected will actually develop a precancerous lesion, and an even smaller proportion will develop cancer. The precancerous lesion that we concern ourselves with is called HSIL. That stands for high grade squamous, because it's always epithelial, intraepithelial lesion, HSIL. And that's the lesion that we're looking for instance, when a woman is having a cervical pap smear. If an HSIL lesion is noted on a visualization of the cervix through a colposcopy and confirmed on biopsy, then the idea is to treat it, to remove it, to prevent progression to cancer. So most likely we develop a cell-mediated immune response that controls the virus. And for some reason, in a small fraction of people, that immune response is not sufficient. And so they do end up developing a lesion. So the other piece of bad news is that even though a small fraction of people who have HPV will develop a cancer, if you think about the denominator, it's a very large number. It's a very high proportion of the world's population. Now, for instance, we're talking about cervical disease and women. The end result is that approximately 500,000, probably a little bit more, women will develop cervical cancer every year, and approximately 250,000 women will die every year of cervical cancer globally. The problem is primarily found in areas of the world where the cervical cancer screening programs are not as well established. And so it's primarily a problem of the Southern Hemisphere. And unfortunately, there's a lot of overlap with countries where there's a high HIV incidence as well. And so the problem is compounded by the HIV epidemic. So that's the number of women who die is unacceptably high. Pardon me. So now we come back to a piece of good news, which is that, in fact, there is something that can be done to prevent most, if not all, of these cancers. It's a combination of two different things, both of which are gaining some momentum. And one of the reasons I'm super excited to talk to this group of medical students is because you're the future, and you're the ones who are going to carry out our dream, which is actually elimination of cervical cancer and HPV-related cancer in general. I'm old enough, for instance, that when I grew up, we didn't have the measles vaccine, and I had a good case of measles myself. And since we have the measles vaccine now in the form of measles, mumps, and rubella, in point of fact, the only case of measles I've ever seen is my own. Many of you will never see a case of measles because of the vaccine. There are problems with measles vaccination in different pockets of the world, and in those pockets you can still see some cases of measles. But I'm mentioning this as an analogy because I'm hoping that in the course of your careers, many of you will see some cases of HPV-related disease, but I'm hoping not too long afterwards, you're going to stop seeing them And then someday when you're on a holographic webinar with the IFMSA people in the future, you're going to tell them the history of HPV-related cancer and how it is unlikely that they will ever see one. So how are we going to actually accomplish that? It really depends on your age group. So if you're young, and by that I mean under the age of 26, and ideally young enough to have not yet initiated sexual activity, the best answer is HPV vaccination, i.e. preventing initial infection with the causative agent in the first place. And then for the people who are too old for vaccination, or for whom vaccination is not available, because in many countries around the world it's too expensive, and the second best alternative is to try and prevent the cancers that have occurred as a result of the infections that have already occurred because the person couldn't be vaccinated. So these are primarily women who have HSIL that's discovered through a screening process and then treated to prevent cervical cancer. So we're hoping that there will be improvements, and there are some improvements on the horizon, both in our ability to vaccinate populations and in doing cervical screening for those too old to vaccinate in a more cost-efficient way, so that cervical cancer will be a disease of the past. And other HPV-related cancers as well, especially anal cancer and oropharyngeal cancer. So the World Health Organization, for example, is creating as one of its goals elimination of cervical cancer. And we, myself at UCSF, and in my capacity as an officer of the International Papillomavirus Society, are very strongly supportive of that and going to work very hard towards that goal. And one of the methods that we are planning on using to help achieve that is the International HPV Awareness Day campaign that we'll be talking more about. So I look forward to your next question, Madupi.
Thank you so much, Joel, for that. That was very interesting, and I think it's nice to see how diseases evolve, and we hope that as well HPV becomes something of the past, just like measles that you said. Yes. So the next question I'll be asking you, campaign. It is our view with us because International HPV Awareness Day campaign was your idea, you had the vision for it, and we are honored in participating so far in the campaign. And I'd like to know, what was your founding vision for the campaign? You know, what was your inspiration for such a huge and now successful campaign? And how do you see it being sustained, as it's obviously something we want to do every year? So how do you see it being sustained? Thank you.
All right, thanks, Madupi. I think I got the entire question this time. I am the immediate past president of the International Papillomavirus Society. So that means that I was the president just before the current president, Silvia de San Jose. And when I was president, I had this idea that we should be doing more to talk about HPV. When I say that, I really mean that in the most literal sense. We are the International Papillomavirus Society, and our society focuses on not just human papillomavirus, but also animal papillomaviruses and, pardon me, all their diseases. But HPV is our main focus, obviously. And one of the things that struck me at the time was that there are a variety of different campaigns already around in progress. There are different kinds of cervical cancer awareness campaigns. There are also HPV vaccination campaigns. A good example of the former is the UICC, the Union Internationale contre le Cancer, runs a cervical cancer day, which was a few months ago. So there are definitely already some efforts in progress to help make people aware of cervical cancer and the importance of vaccination. Where we saw an important gap in what was available today was a lack of awareness of HPV itself. Let me give you an example. Although I spend most of my time at UCSF doing research, I do see patients. I'm an infectious disease doctor, but I run a dysplasia clinic, a very specialized dysplasia clinic, which is actually aimed not at cervical cancer prevention, but anal cancer prevention. It's called the Anal Neoplasia Clinic Research and Education Center, ANCRE. And if any of you happen to be in San Francisco, please call me and I will be thrilled to show you our very unique facility. But what always strikes me is that when I talk with patients, and I know this is true of talking with women who come into cervical dysplasia clinics as well, is that people know that they need to get screened. Women know that they're supposed to have cervical pap smears. Some people know that they're supposed to get vaccinated or get their
Hi, Joel. I think you accidentally muted yourself. I think you are muted accidentally. Yes, we can no longer hear you.
Can you hear me now?
Yes.
Hello?
Yes.
Yeah.
Yes, we can hear you.
I don't know actually what happened because I didn't touch anything. But I can see on my desktop that the microphone thing went red, and I kept on pressing it to try and make it unread, but it wasn't doing it. So I suspect this is a connectivity issue. So my apologies.
Okay.
So you need to tell me
No.
where you last heard me say something.
You were talking. You were talking about women in clinics.
Okay.
Yes.
So pardon me if I repeat myself,
No problem.
because I don't know exactly where you stopped hearing me. But essentially, it became very obvious to me that people don't understand the connection between the diseases that they're coming in for care for and the reason that they got it. In other words, they don't understand about HPV, and they don't understand, for instance, that it's a sexually transmitted virus and how common it is. So we felt that it was important for people to really understand about HPV itself. There are a lot of different issues around HPV compared with vaccination per se and cervical screening per se. And in a way, it's there's something satisfying about HPV because of its commonality, because it really does unite everybody everywhere. This is a problem that every single country has. Doesn't matter if you're rich or poor, doesn't matter what religion you are, doesn't matter what your sex is or how old you are. This is something that unites humanity as a problem. And so we thought that this would be a great way to approach the problem, not only to give people information, but to motivate them to take action that we think can help prevent some of the problems due to HPV. So, for example, if you have a conversation about HPV, we hope that that then makes people who are thinking about vaccination, that it makes a little more sense to them. Likewise, if a woman understands HPV, then perhaps she will be more motivated to get a cervical cytology, or if cervical cytology is not available where she lives, to perhaps band together with others in her community to put pressure on authorities in the location to make sure that some of those resources are provided. So really, the main distinction, if you will, between this campaign, the International HPV Awareness Day campaign, and pre-existing campaigns is a conscious decision to talk about HPV itself. And one of the things that we've learned since the campaign was launched earlier this month is that there are some advantages, mostly advantages, but a few disadvantages to this approach. And I'm happy to tell you a little bit about some of the experience that that we had in that. I wonder if, Madupi, you could confirm that you're still able to hear me. Hello?
Yes, I can still hear you. We are listening. Yes, yes, we can hear you. Hi, Joel. We can hear you. We can. Hi.
Can you hear me now? Can you hear me? Hello? Can you hear me?
Hello? I think we have lost wind.
Can you hear me now?
Yes, yes, we can.
This is really spotty.
Yes, yes, you hear you. Yes, yes, absolutely.
Okay, so you can send me a message saying when you can't hear me, I think.
We can hear you, Joel.
Okay, all right. Super. So, so basically, the idea was to run this global campaign.
Okay.
And one of the interesting parts about this, and I know that you as an organization appreciate this very well, is that there are enormous cultural differences, obviously, around the world. And when you have made a decision to talk about HPV, it's a little risky because you're talking about some issues that bring up a lot of uncomfortable discussions. For instance, if you made a decision to talk about HPV, then you've made a decision to talk about sexually transmitted infections. And the language around that and the comfort level and the ability to do that does vary enormously around the world. Different cultures have different ways of approaching this. Some are quite comfortable talking about these issues openly. Others are not comfortable at all. So since this was a global campaign and cultural needs vary a lot, one of the approaches that we decided to take was to make it a modular campaign, if you will, which is to provide campaign materials as a whole to our partners, but put them together in a way that allowed our partners to pick and choose from the materials that they thought were most appropriate for their setting. So basically what we did was solicit interest from the part of organizations in countries who we thought were appropriate for the task at hand, and solicit them for levels of interest in participating as operating partners. IPVS itself is a pretty small organization with limited resources, and so we decided to engage with our partners as the primary facilities
Hi, Joel.
to actually run the campaign on the ground in those locations. And I think that was a very good approach, because the campaigns were run, I think, in over 40 countries, and they varied a lot depending on what the needs were. Sorry, can you hear me?
Yes, yes.
Okay. Yeah, so the way the campaign was run really varied a lot from place to place. The kinds of activities that were performed varied from country to country. There were press releases, there were educational sessions, there were rallies, there were posters and various kinds of postcards put in key locations. And then we also mounted a very extensive digital and social media campaign. We used Facebook and Twitter and Instagram, and we did something that I had never done before called a thunderclap. I don't know if any of you have ever participated in one, which is basically designed to send out messages simultaneously around the world to kind of amplify the magnitude of the impact. So the amazing thing is that we reached over 2 million individual users just on the using social media, and we did it amazingly inexpensively. I think we spent only about $700 to do that. So social media are obviously a very powerful tool for reaching people. But we are also aware that people's access to social media varies enormously around the globe. And so we did feel that having a variety of approaches, ranging from in-person sessions to printed materials to social media, was going to be the way to go. As far as the sustainability is concerned, we were really, really encouraged by the response to the campaign and the reach that we had. We do have some measures already of increased HPV awareness, but we were also very aware that this was our first dip in the waters, if you will. And we originally had only 10 target countries as far as where we were putting most of our resources. And our plan is to eventually cover every country in the world and have the materials translated into every language so that everybody has access to the materials. And that's going to take, obviously, a lot more work. We also, I think, are going to put in more formal programs for assessing the success of the various things that we're doing, so that we can try and learn better what works well and what is working a little bit less well. So we still have an awful lot to learn. But again, one of the reasons I'm so very excited to talk with you guys is that we would dearly love to have IFMSA as one of our partner organizations for next year, because you guys are the boots on the ground, and I'm also very aware that you're the future of the medical profession. And so we would love to work closely with you to help coordinate the campaigns in whatever country you happen to be in. So I'm happy to take your next question, Madupe, and hope that you can continue to hear me.
Okay. Hi, Joel. The last question we had network issue. So
Question,
okay.
could you could you repeat the question, please?
Okay, can you hear me now?
Now I can hear you.
The next question. Okay, good. Okay, so the next question has to do with HPV itself. It has to do with the trend of HPV. That field for over 20. From your experience, what are the major changes that have occurred between now and working with HPV?
Oh, that's such a good
Especially
question.
regarding how people now know.
So I don't know if you can hear me, Madupi, but I missed the very last part of your question. If you could just repeat the last part, please.
Yes. So especially regarding how the infection, how its course has changed, and how people now perceive HPV.
I think I still missed that. And one thing that you could do maybe is email me that question and I'll start answering the question and just try and make sure I catch the end of it. Do you still need me to pause, or can I go ahead?
Okay, I was saying regarding public perception.
Okay.
Hey, Joel.
So your question is how things have changed in the HPV field since I started, and how public perception of HPV has changed. Is that the question? So I'll start answering. Just let me know if you can still hear me. So a lot has changed since I started in HPV. Basically, when I started in HPV, the connection to cervical cancer actually wasn't even established. Harold Zerhausen from the German Cancer Institute in Heidelberg published the first paper in the mid-1980s isolating HPV-16 from a case of cervical cancer. And HPV had been known, of course, before cervical cancer, but it was not at all clear that it was the causative agent. And so there was a lot of epidemiology work that went on, along with a lot of diagnostic test development, which was necessary too, to try and establish the actual connection between the virus and the cancer. So over the next 20 years or so, all that work was being done to prove that HPV was actually the causative agent. For those of you interested in history of medicine, actually before HPV, it was thought that herpes virus HSV1 and HSV2 in particular were thought to be the cause of cervical cancer. Done to prove that developing cervical cancer is many-fold higher when you have HPV-16 or other oncogenic types, that you basically almost never get cervical cancer when you don't have HPV. And then fulfilling sort of the virologic equivalent of Koch's postulates that we have for bacteria, it was shown that HPV has all the molecular tools to explain its causation of cervical cancer because of two genes in particular, the HPV E6 and E7 genes, which inactivate two important tumor suppressors, P53 and RB. So it was clear that HPV was necessary and insufficient by itself for causing cervical cancer. But once that connection was made, then that opened the doors to several other very important developments. One development was the development of HPV testing as a diagnostic tool. Remember, we're looking for cervical high-grade disease as a way of treating it to prevent cervical cancer. And it was clear that cervical pap smears themselves actually have quite limited sensitivity. In many places, it's only about 50% sensitive, which is not a good screening test. And the only reason that they work as well as they do is because we recommend that women have them repeatedly over and over and over again. And it's the cumulative sensitivity that really allows most women to have their cervical high-grade disease identified and treated before it progresses to cancer. So we needed something better. And a lot of work was actually done to try and develop HPV diagnostics as either an adjunct to cervical cytology or even on its own. And in fact, over time, a lot of work has been done that shows that HPV testing is probably superior to cytology testing as a screening test for cervical cancer. And over time, we'll see probably HPV testing being done first and then cytology being done afterwards, potentially amongst women who are HPV positive. One of the big issues with HPV testing, though, is it's expensive. And so a lot of work has been ongoing in developing countries to make the test cheaper and also to make the test a point of care test, because one of the things we know is that it's very difficult for a lot of women to come for repeated visits to get their cervical cancer prevention services done. And so the goal is to get it all done in one visit. So a woman comes from her village or her town to the clinic. She gets a cervical swab done. It's tested on the spot for HPV. If she has a cancer-causing HPV type, then she may undergo the next step in the evaluation, which is a colposcopy, and then potentially get treated right on the spot using a technique called see and treat. And so in theory, at least, there are lots of issues around this, but this is where we're going. A woman can get HPV tested and treated on the same day. There's also a rationale to vaccinate those women. So she may get treated and vaccinated in the same day. And if she brings her children, particularly her daughters, but in some cases sons as well, they may get vaccinated too. So the goal is to try and provide as many comprehensive HPV cancer prevention services as possible in one visit. So that's sort of one big direction that we're moving. Another big direction is the vaccine itself. So here's where molecular biology is so important. And I have to say, with no bias whatsoever, that the vaccine is one of the great public health advances of the 21st century. It was only through knowledge of the genomic structure of HPV and the clear association between HPV and the precancers and the cancers that allowed people to design the vaccine that you've all heard of at this point. The vaccine, there are a few of them that are out there, but they are very, very safe and they're highly effective. And they will eventually eliminate cervical cancer and every other HPV-related anogenital cancer, as long as we improve our ability to deliver the vaccine to more people. Some people ask, why haven't we seen a reduction in cancer yet? And the answer is, you have to think about the natural history of this infection and this disease, because generally the time it takes to get from HPV infection to a high-grade lesion, the precursor, is relatively short. It's about 2 or 3 years usually. But it then may take, in many cases, decades for that high-grade lesion to progress to cancer. So somebody who gets infected, say with HPV-16 today in 2018, may not expect to develop cervical cancer if nothing is done for at least 20 years. Of course, there's a lot of variation around that, but it does take that long at least. So if we prevent that person's infection in 2018, we wouldn't expect to see a reduction in the cancer rates for another 20 years or so. So some people say, well, of course, the vaccine isn't working because we haven't seen the reduction in the cancer rates yet. And of course, that's wrong thinking. What we have seen is very clear indicators of future reduction of cancer. For example, in countries where they have a high uptake of HPV vaccination, the rates of HPV in the cervical swabs of birth cohorts that have been vaccinated are dramatically lower for the vaccine types. They're actually unchanged for the types that are not covered in the vaccines, as a negative control, if you will. We're also seeing dramatic reductions in genital warts in populations that are vaccinated with either the quadrivalent vaccine or the nonavalent vaccine. These two vaccines have HPV 6 and 11 in them that cause genital warts. And in those countries, we are already seeing a big reduction, which is not surprising because warts really don't take very long to develop. So this is a really good indicator of the population-based efficacy of the vaccine. We're also seeing clear reductions in high-grade lesions. Again, these only take 2 to 3 years to develop mostly. And so not surprisingly, even now, we're seeing clear reductions in high-grade disease. So everybody is very confident that this will translate ultimately into reductions in cancer, but it is going to take a little while to prove that. So I'd say the last big change in the field is one of the more challenging ones, which is how can we better treat people who already have invasive cancer, because the mortality rate is too high, and also how can we better treat people with high-grade disease so that, for instance, we don't have to do a big ablative procedure removing large areas of tissue and causing side effects. The beauty of HPV and its importance in this disease is that it gives us an opportunity to do something virus specific. So for example, many of you are familiar with using acyclovir to treat herpes simplex virus related lesions. And that is a really effective drug. It doesn't actually cure your latency, but it really makes your active disease go away. And it does that in a very safe, very effective manner. And it does that so because the molecular mechanism by which the drug works is very targeted to a viral gene product, in this case, HSV thymidine kinase. So we would love to have a method to treat HPV-related disease that relies on interfering with an HPV gene, E6, E7, or whatever the case may be. This has been very challenging to develop in the laboratory so far, which is the reason it hasn't happened yet. And so we're still kind of stuck with a rather medieval approach to treating these lesions, which is basically to remove what we can see, usually with an electric knife or some other destructive method. So it's not ideal. but we're moving towards more elegant virus-specific approaches using newer, very exciting developments in molecular biology, such as CRISPR, better approaches to stimulating the immune response to improve therapeutic vaccines. Many of you have probably heard of this new class of drugs called the checkpoint inhibitors, which kind of reawaken your immune response. So these are all changes that we're hoping to see come into the HPV field that will enhance our ability not only to prevent infection and the cancers that result from those infections, but also to better treat the people who we have failed by allowing them to get infected and allowing them to reach a stage of disease where they desperately need treatment to avoid serious morbidity and mortality. So I'm happy to get your next question. Hope you can still hear me.
Thank you for that. That was very enlightening. Can you hear me?
I can.
Oh, perfect. So that was very enlightening, and there were a lot of important points that you mentioned. So I'll just go ahead to the next question, which is a practical one, and which is something that you have already been hinting about since we started the webinar. So it's just, can you give us, specific examples about how medical students such as us can have more active roles? Can you give us points? How could we take on more active roles in furthering HPV awareness? And how can we sustain this being medical students? That's the question.
A wonderful question, Madupi. So there are lots of things that you guys can do. So the first is you are actually an extremely important voice in the global scene. And so having your organization partner with the International Papillomavirus Society for the future HPV Awareness Day campaigns and other educational campaigns that we plan to mount would be, I think, an extremely powerful and symbolic and practical partnership. So I'm hoping one of the outcomes of this webinar will be a more regular contact between our two entities so that we can work together to achieve some of the aims that I think we all have. So that's one important thing. I'd say the second important thing is that you guys are representative of medical schools all over the world. And so you have a global reach that many other organizations don't have. And so you, as representatives of your medical schools, have a lot of influence with your colleagues in your classes. And with my help, with the help of IPVS and others, we would be happy to assist you in various kinds of educational events that you would like to have or you think might be helpful for you to have with your medical student colleagues in your location. Because really your influence comes from being local leaders and being able to explain to your colleagues what seems to be important on the global scene. And in my very unbiased opinion, HPV is really very important for the reasons we've talked about. In many of your countries, cervical cancer is in the top 2 or 3 causes of cancer-related death amongst women. So it really is critical, and it is made doubly critical by the fact that, for the reasons we've mentioned, we think this is preventable. So it's bad enough when you have a problem that's common and nothing is being done about it, but when you have a problem that nothing is being done about it, but something could be done, then I think we have a moral and ethical imperative to do something. So you guys can play an important role with your in your capacities as representatives of this organization. Then, I think the other thing that you all could do really depends to some degree on your own professional interests. I think probably many of you are interested in primary care. Many of you are interested in pediatrics. Many of you are interested in gynecology. Some of you may be interested in HIV care. We haven't really talked much about this, but the HPV-related problems are all greatly magnified in the setting of HIV infection and other forms of immune compromise. That's, for instance, one of the reasons why anal cancer is so important in HIV-infected people. And so in your capacities as people who will be taking up positions in these various specialties, you can be the torchbearers there as well. So in the United States, for example, where we don't have very good school-based vaccination programs, the primary care providers are the first line for vaccination. The family care physicians and the pediatricians have enormous influence over who gets vaccinated and who doesn't. For those of you who are interested in public health and who go to your towns and your villages, with various preventive measures, this is something that you can incorporate into your toolbox to make sure, for instance, that all of the women who should be vaccinated have access to vaccination, and all of those who are of screening age have access to screening and treatment. So I would summarize my answer to this question would be in two ways. One is, as medical students right now, I think you have an incredibly important role to play in this campaign. And then as future doctors and practitioners, you have incredibly important roles to help realize some of the very ambitious plans that I've articulated for you. And I also hope that some of you are interested in basic science, because we really won't make progress until we have a better understanding of all the molecular mechanisms by which HPV does its damage, and better ways of understanding the host immune response so that we can control it. So,
yes,
look forward to my next question.
Thank you, Joel, for that. I'm sure you have inspired many of our viewers, and this is the start of long collaborations between us. I'm sure that many medical students will be involved in HPV, and as we move on to become healthcare professionals, will be maybe for people that are just joining. So about changing in HPV since we started, but now as people that are interested in furthering our knowledge, we want to know the newer developments. Is there anything new that's happening in HPV care? Is there anything trending? Are there new developments or in treatment that you know that yes, Joe?
I'm having a little bit of difficulty hearing your last question. If you could please repeat it, Padupi. Can you hear me?
Okay, I'm asking.
Hello?
Just I can hear
Great.
you perfectly.
Great. Sorry, could you please repeat the question because you faded out?
Okay. I'm asking about any new disease patterns in HPV or any new developments in
So I didn't actually hear most of the question, but I think I know what you're asking. I think you're asking if there's any new developments in treatment of HPV. Is that correct?
Yes, yes.
Okay.
New.
So Unfortunately, the answer to that question really varies enormously depending on where you are. The approach to screening and treatment of HPV-related cancers is very different, for instance, in developed country settings compared with developing country settings. In a developed country such as ours, in the United States, the main approach to treating a cervical high-grade lesion is a procedure called loop electroexcision procedure, or LEEP, or an electric knife, if you will, is used to excise the lesion, trying to remove as much of it as possible without taking off too much of the abnormal tissue. And there are some complications associated with that, one of which is, it's kind of an unfortunate term, it's called cervical incompetence, where basically the loss of some of the tissue at the transformation zone results in a woman's inability, in some cases, to keep the baby in because the cervix isn't as strong. And so she may undergo a premature delivery as a result of that. But it's a very effective technique. It also, unfortunately, takes a lot of resources to do this procedure, and typically multiple visits. And so it's not a very practical procedure on a routine basis in many developing country settings. So in many developing country settings, and these do vary from place to place, the emphasis is more on trying to, again, achieve as much as possible in one visit, knowing how difficult it is for women to return for multiple visits, and also trying to treat in as resource conserving manner as possible. And so in many of these settings, the approach is called see and treat, where not usually MDs, but other healthcare professionals such as nurses are trained to visualize the cervix under magnification, not necessarily formal colposcopy. And then if there's any suggestion of a lesion after applying 5% acetic acid, then they will treat, typically with a technique called cryotherapy, which basically involves putting a probe onto the cervix and basically freezing the whole cervix. It kind of creates what we call is like a snowball. And it's got the advantage of being relatively inexpensive and allowing the woman to be treated. The disadvantage is that in many cases, the women actually don't have a high-grade lesion, and so a fairly substantial number of women are overtreated. But that's a choice that people make, and in trying to balance the risks and the benefits of not treating somebody. So again, we're not there yet, but what we're hoping is that a combination of HPV testing and better cytologic techniques will allow more specific choices of treatment. And the treatment itself really does need improvement. There are some things in the pipeline which may be better, but at the moment, I'd say that the improvements in the quality of the treatment that we apply are slower in coming, I'd say, than the progress that we've already discussed in terms of vaccination and improvements in HPV diagnostics. So this is very much an area of future research, and I'm hopeful that some of the folks on this call would be interested in pursuing that. We really need that very badly.
Yes, thank you. I hope they'll be interested too. I think that with this webinar, there are a lot of people that would open up their hearts to HPV work, and I think that you will have a lot of people to work with from us.
Well, I'd like to invite all of you to contact me if you have any questions whatsoever. I don't know if you have my email address, but you should feel free to make it available. And
all right.
And should any of you find yourselves in San Francisco, I would be delighted to meet with you and show you around. extend a warm welcome to everybody if you happen to come by our beautiful state and city.
Thank you. Thank you so much for that. So we're rounding up now. The final question is, now you've told us a lot about HPV and we are grateful. So what is your take-home message for the people watching? What do you have any parting words for us to inspire us about all you said?
I'd say that the only parting words I have for you is I'll share you guys with you something I said to my son every day when he would go off to school. A lot of parents say to their kids, goodbye, have a good day, be safe. And of course, I would wish the same thing for my son. But in addition to that, I always said 3 words to him, and they apply to you guys as well. And they are, change the world. You're in a unique position to do things, and you can change the world. And Lord knows the world needs some changing. But I think with the enthusiasm and talents of this group, I really feel optimistic that the world will get better and you guys can do it.
So much. That was really inspiring, and I think we will change the world together.
Excellent. Okay.
Yes. So we have been collecting questions through the chat box. So I'll just read. We have a question for now. So I'll read this one to you, and you can answer it. Any other questions I will be sending to your email.
Very good.
Okay. Question is from Ella. She says, "Good morning from Peru. I want to know about the side effects of the vaccine." She has heard that it has been related to Guillain-Barré syndrome, so she wants to know about the side effects of the HPV vaccine.
Excellent question. So the vaccine, of course, does have side effects like every other vaccine, but these are primarily local site injection reactions. There has been some concern from the beginning that there may be some autoimmune reactions as a result of vaccination. So many different world bodies have been looking very, very carefully at all kinds of anticipated and unanticipated side effects, including immune reactions like Guillain-Barré. And the data are really very clear at this point, which is that there is no increased risk of vaccination for this. Lots of data have been collected over, well, tens of millions of young women have been vaccinated at this point. And there has not been any evidence whatsoever of any side effect of this nature related to the vaccine. When you vaccinate so many millions of people, it is expected that some cases of these diseases will occur simply because they have a known incidence and we expect a certain number to occur. So there's going to be Guillain-Barré syndrome, there's going to be multiple sclerosis, you name it, it's going to happen when you have a population this large. But the data thus far do not suggest that the incidence of any of these diseases in the women who have been vaccinated so far is any higher than would be expected if they weren't vaccinated. So this is a very safe vaccine.
Okay, thank you so much, Joel, for that. I'm sure she has her questions answered. So I have another question that was sent to my email personally. This question is from Elizabeth Peters from Nigeria. So she asks that she has heard that the vaccine is more effective for women and girls who have not yet started to have sexual relations.
I may
So
have
for
missed.
the older population who are not yet infected, with the vaccine still work, or are there other focuses for prevention of that's the question.
Okay, great question. So the vaccine is preventive primarily. It is meant to prevent initial infection with HPV. It really has very little benefit against the development of an HPV-related lesion if you've already acquired that HPV type before vaccination. So that is the main reason we prefer to vaccinate people as early as possible, and ideally before initiation of sexual activity, so that the protection from the vaccine would be maximal. But having said that, there are still many women who would benefit from vaccination, even if they've already initiated sexual activity and even if they've already acquired a few HPV types. So the vaccine that is available in the United States now, and which will, for example, be increasingly available globally, is called the non-valent vaccine, meaning it's got 9 different HPV types. In many countries, the bivalent vaccine, which contains 16 and 18, and the quadrivalent vaccine, which has 6, 11, 16, and 18, are the vaccines that are available. But the point is, relatively few people have already been exposed to all the HPV types in the vaccine by the time they get vaccinated. So if, for example, you have access to the non-valent vaccine with 9 types, and you've already been exposed to 3 HPV types, you're still going to benefit from vaccination because you might still get protection against the other 6. So we don't actually even bother to do any kind of tests to see if a woman has already been exposed to HPV at the time of vaccination, because we think that she's going to benefit one way or the other. And so we primarily use age as the cutoff for deciding who gets vaccinated and who doesn't. In the United States, for example, where most of the cost of vaccination is borne by insurance companies or the government, the age cutoff is 26. And so if a woman is 27 years old or 28 years old and asks about HPV vaccination, the vaccine may still be effective for her and help her, but she would probably need to end up covering the cost of the vaccine herself. But it doesn't mean that the vaccine wouldn't be beneficial. In other countries where the cost of the vaccine is very high or too high for the healthcare system, there does need to be some prioritization over who gets vaccinated. And so that does tend to be younger people because they're going to get the most out of the vaccine. But for the older women, the vaccine is safe pretty much at all ages. And when you're a little bit older, then the decision is truly more of an individual one. And whether, for instance, if the cost is not covered, whether the woman can afford it. So I hope that answers that question.
Yes, yes. I'm sure she's satisfied with the lovely answer you've provided. So for now, I think those are the questions we'll be able to answer on the live interview. But any other questions, if you have questions, please send them to my email, aids@ifsa.org. I will be happy to pass them to Joel, happy to answer them. So thank you very much.
Well, thank you. I wish the connection were a little bit better, but it appears that you've heard me, even though I've had some difficulty hearing you.
Thank you so much.
But I really appreciate the opportunity to talk with you guys and wish each and every one of you the very best, and thank you for everything you do.
Yes. Thank you so much, Joel. So thank you everyone for staying till the end of this webinar. You can all expect a blog post that will be coming following this. For those who haven't watched it, they'll from the beginning till the end, so you'll be able to catch up. And of course, if you have any HPV related, send them under the FMSA programs. And we're excited to have had everyone listen to this. And we hope that we'll see you at whatever is the next webinar we'll be having. Thank you so much for staying. So bye-bye.
Bye-bye.
Everyone. Thank you.